A 21-year-old female patient reported to the Department of Orthodontics and Dentofacial Orthopedics, Indira Gandhi Institute of Dental Sciences, with the chief complaint of forwardly placed upper front teeth with increasing frontal spacing. There was no history of medical ailments. Extraoral examination revealed no gross facial asymmetry, incompetent lips with interlabial gap of 4 mm. She had a mild convex profile with a posterior divergence of the face. The occlusal examination revealed angles class I molar relationship bilaterally. The upper incisors showed pathologic anterior migration and extrusion of right central incisor, impacted 2-3 in crossbite in relation to 2-2 and 2-4, whereas the lower arch segment demonstrated mild crowding in the anteriors. Periodontal examination and charting were performed, including the assessment of probing depths, clinical attachment levels, full mouth bleeding, and plaque scores. The other findings were reddish-pink colored gingiva with brownish pigmentation and erythematous in relation to 1-1, 3-3 with pus discharge in relation to 1-1 on digital pressure. Periodontal findings were 5 to 7 mm of generalized pocket depth, horizontal bone loss, 13 mm in 1-1 and 12 mm in 2-6, vertical bone loss. Mobility test revealed grade 3 mobility in 1-1 with labial pathologic migration, secondary trauma from occlusion, and grade 1 mobility in 3-1, 3-2, 4-1, and 4-2. Given the presented information, a diagnosis of generalized aggressive periodontitis with anterior dental spacing was made. Before starting periodontal treatment, extraction of 1-1 was done due to its very poor prognosis. The cephalometric analysis revealed class I skeletal base with proc-lined upper and lower anteriors with protrusive lips. Introduction. Patient demographics. Age, 21 years old. Sex, female. Country, India. Nationality, Indian. Patient chief complaint. My front teeth was placed forwardly with increasing frontal spacing. Initial examination findings. Extraoral examination, no gross facial asymmetry, incompetent lips with interlabial gap of 4 mm. She had a mild convex profile with a posterior divergence of the face. Intraoral examination, the occlusal examination revealed angles class I molar relationship bilaterally. The upper incisors showed pathologic anterior migration and extrusion of right central incisor, impacted 2-3 in crossbite in relation to 2-2 and 2-4, whereas the lower arch segment demonstrated mild crowding in the anteriors. Periodontal examination and charting were performed, including the assessment of probing depths, clinical attachment levels, full mouth bleeding, and plaque scores. The other findings were reddish-pink colored gingiva with brownish pigmentation and erythematous in relation to 1-1, 3-3 with pus discharge in relation to 1-1 on digital pressure. Periodontal findings were 5 to 7 mm of generalized pocket depth, horizontal bone loss, 13 mm in 1-1 and 12 mm in 2-6, vertical bone loss.
Since the patient was found to have a serious periodontal disease that is causing damage to the structures supporting the teeth, and there's also a noticeable problem with the front teeth shifting forward, the dental team decided on a two-step plan to treat these issues. The initial phase involves addressing the periodontal issues, followed by the subsequent orthodontic phase. In the first part of the treatment, the focus is on dealing with the periodontal disease and its effects. This is important because a healthy foundation for the teeth is necessary before we can work on fixing their alignment. So the initial phase of the treatment plan is periodontal therapy, which involves 5 phases. The emergency phase or preliminary phase in our case is the extraction of tooth 1-1. Since this tooth presents grade 3 in mobility test with labial pathologic migration, its prognosis is very poor. Etiotropic phase, also known as phase 1 therapy, involves plaque control and patient education. In this case, it involves removal of calculus and root planing, antibiotic therapy, maintenance of phase 1 and re-evaluation of phase 1. Surgical phase, also known as phase 2 therapy, includes full mouth open flap debridement, maintenance of phase 2 and re-evaluation of phase 2 therapy. Restorative phase, also known as phase 3 therapy, includes final restoration, fixed and removable prosthodontics. In this case, the processes that are included are replacement of missing tooth, maintenance of phase 3, and re-evaluation of phase 3 therapy. maintenance phase or the last phase, which is the phase 4 therapy. This phase includes periodic checking of plaque and calculus, the condition of the gingiva, occlusion, tooth mobility, and other pathologic changes. Reevaluation is performed every 3 months. Once the gum issues are under control, the second phase will begin, which involves using orthodontic methods to adjust the alignment of the teeth, especially the ones at the front. The orthodontic treatment plan, where the fixed appliance system is used to treat the improper alignment of teeth by extracting teeth 1-4, 2-4, 3-4, and 4-4 to create the necessary space for proper tooth alignment and bite correction. The appliance and treatment plan mentioned are commonly used in orthodontics to achieve the desired outcome of a well-aligned and functional bite.
This clinical report describes an interdisciplinary periodontics and orthodontics approach for the treatment of a periodontally compromised patient with incisor migration and anterior spacing. The common causes of periodontitis is increased proclination and irregular spacing and traumatic occlusion. The patients with poor periodontal health and pathologic migration should be co-evaluated by orthodontist and periodontist together to make a treatment plan that is individualized to the patient, keeping the treatment needs in mind. Below shows the collaboration between periodontal therapy and orthodontic treatment. Since the patient was diagnosed with aggressive periodontitis along with pathologic anterior migration, the treatment was planned to be done into phases, the first being the periodontal phase followed by the second orthodontic phase. For the periodontal treatment, the successful orthodontic treatment with aesthetic and functional results using fixed appliances includes periodontal therapies, such as periodontal flap debridement. The orthodontic treatment is a bipartite procedure regarding the periodontal tissues, so it is of utmost importance to assess the need and outcomes of interdisciplinary approach in different physiologic, pathologic, or deliberate alterations in tooth positions to maintain harmonious periodontal and orthodontic relations.
Outcomes of the interdisciplinary treatment. Comprehensive evaluation. Both the orthodontist and periodontist thoroughly examined the patient to determine the degree of periodontal disease, incisor migration, and anterior spacing. The examination was useful in choosing the best course of treatment. Collaborative treatment planning. Together, the periodontist and orthodontist created a coordinated treatment strategy. They took into account the patient's overall oral health objectives, the patient's tooth mobility needs, and the periodontal status. The periodontal and orthodontic components of the treatment were successfully integrated because to this partnership. Clinical improvements. These improvements can be made in terms of tooth alignment and occlusion as well as in terms of maintaining the patient's periodontal health and overall oral well-being. Clinical improvements. These improvements can be made in terms of tooth alignment and occlusion as well as in terms of maintaining the patient's periodontal health and overall oral well-being. Long-term success. Patient cooperation is important for optimum progress. Treatment efficacy. Avoiding problems and maintaining oral health in the long run. Patients can contribute to the effectiveness of dental therapy and advance their oral health by actively participating in their own care.
The case presents a 21-year-old female patient with pathologic migration of her maxillary incisors resulting to spacing and proclination of her teeth, impaction of her left upper canines and crowding of the mandibular anterior, and severe periodontal disease. Her severe periodontitis was believed to be the cause of the migration of her maxillary right incisors with grade 3 mobility, as the patient claimed that there were no previous spacing and mobility. According to Taiki Morikawa et al., 2021, the destruction of periodontal tissue induces pathological tooth movement, resulting in various types of malocclusions such as crowding or spacing in the dentition. Patient underwent scaling and root planning in addition to flap elevation and debridement, orthodontic fixed therapy with high access to plaque control, and oral prophylaxis to improve initial periodontal conditions. A study by Ninal et al. 2022 has found that orthodontic treatment after periodontal stabilization does not have any detrimental effect on periodontal health in adult periodontally compromised orthodontic patients and may add to the benefits achieved by periodontal treatment alone. Patients' 4 premolars were then extracted to allow for the proper alignment and functional occlusion of the impacted tooth 23. Telma Martins de Araujo et al. 2019 states that tooth crowding and protrusions demand rigorous attention during orthodontic planning that includes the extraction of first and second premolars, especially in cases with characteristics such as dentoalveolar bone discrepancies, maxillomandibular relations, facial profile, skeletal maturation, and dental asymmetries. After the patient has undergone a combined periodontal and orthodontic treatment, her periodontal health has shown no signs of inflammation and bleeding, and has exhibited a probing depth of less than 4 mm. The elimination of the maxillary anterior spacing has also improved bone support and provided good access to plaque control. A research study by Egil Zasirenskin et al. 2018 states that orthodontic treatment, simultaneously to the periodontal treatment, could be used in the routine treatment of patients with plaque-induced periodontitis, as they found that sites with initial pocket depth of 4 to 6 mm healed after periodontal orthodontic treatment. A study by Guo et al. 2021 has found that although orthodontic appliance promoted plaque accumulation and altered the microbial community of patients with well-controlled periodontitis during the first month of orthodontic treatment, the microbial community returned to the basal composition at 3 months after appliance placement, and the periodontal inflammation during the 6 months orthodontic treatment was under control. For long-term maintenance, a lingual bonded wire retention was applied in the lower arch and in the upper arch, as well as a modified Hawley's retainer to provide a retention protocol and interim replacement for the extracted tooth 11. The pre-treatment and post-treatment cephalometric values of the patient are as follows. SNA angle. Pre-treatment is at 82 degrees, post-treatment is at 80 degrees. SNB angle. Pre-treatment is at 80 degrees and this remains the same for the post-treatment angle. ANB angle. Pre-treatment is at 2 degrees, post-treatment is at 1 degree. GOGN to SN. Pre-treatment is at 30 degrees, post-treatment is at 31 degrees. U1 to Na angle and line. Pre-treatment is at 45 degrees and 17 mm, post-treatment is at 22 degrees and 4 mm. L1 to NB angle and line. Pre-treatment is at 29 degrees and 11 mm, post-treatment is at 25 degrees and 4 mm. Nasolabial angle. Pre-treatment is at 112 degrees, post-treatment is at 107 degrees. Upper lip thickness. Pre-treatment is at 14 mm, post-treatment is at 7 mm. Upper lip strain. Pre-treatment is at 4 mm, post-treatment is at 1 mm. Lower lip to H-line. Pre-treatment is at 5 mm, post-treatment is at 2 mm.
The collaborative approach between the periodontist and orthodontist contributes to the success of the rehabilitation of the patient's oral health that presents aggressive periodontal disease with pathologic migration of teeth. Their collaborative planning ensures both periodontist and orthodontist develop a comprehensive and coordinated treatment plan that focuses in each of their specialties in the field of dentistry. The successful treatment outcome is a result to their combined expertise in their own specialties that leads to higher patient satisfaction, as the result shows a significant improvement in the patient's extraoral features.